So my name's Rupert McShane. I'm a consultant psychiatrist based at Oxford Health NHS Foundation Trust, and I'm an associate professor in the Department of Psychiatry at the University of Oxford. And I've been interested in treatment-resistant depression for quite a long time in the context of using electroconvulsive therapy. But over the last 8 years, we've started to use ketamine as a rapidly acting antidepressant. And this has the potential to transform psychiatry, and I think that will, like all disruptive influences, have good and potentially more difficult consequences. So ketamine, when you use it it's licensed as an anaesthetic, and it's in fact on the WHO essential drugs list, so it's considered a safe drug. But as an anaesthetic, obviously it's only used on one occasion. And over about the last 10 years, the evidence for its use as an antidepressant for people for whom nothing else has worked has been developing quite rapidly. And that started with evidence based on single-dose intravenous infusions lasting 40 minutes or so. And the doses used are much lower than, or much lower than used for anaesthetics, and much lower than drug addicts who are addicted to ketamine take. So there is a problem with ketamine addiction, particularly in China, and people who are addicted typically take more than a gram a day, sometimes 2 to 5 grams a day, whereas the dose that we use is of the order of roughly 40 milligrams over 40 minutes intravenously. So we've been trying to work out how best to use that, and like other people, we found that some patients really respond very dramatically to ketamine. And what's interesting about it is that it's a very short-acting drug, but the effects on mood can last much longer than the drug is around. So, for example, people, when they have the infusion, they may feel quite dissociated, quite weird while they're having the infusion. And if they experience an antidepressant benefit, that'll typically last the order of 10 days or so. But in some people it lasts a lot longer, and people are very variable in how they respond to ketamine. And my personal opinion is that the more sick they are, the more ketamine we need to use to keep them well, and people who are less sick can actually derive a sort of longer lasting benefit. And part of the reason for that is that when people have this weird experience, this dissociative experience, people who are less unwell are sort of able to make use of it in a slightly different way. So that dissociation means that ideas previously very tightly bound to each other, such as the constellation of ideas about one's depression, become less tightly bound. So there's less like a sort of knotted rope, and it's the filaments of the ropes perhaps slightly easier to target. And what that means is that those filaments can move away from the habitual rut of depressive thinking and move to a different sort of focus in one's mind. The problem with depression is that by the time you've been depressed for a long time, you've been practicing those depressive thoughts again and again and again, and you've got really good at them. If you were practicing the violin, for example, and you spend as much time playing the violin as you do with your depressive thoughts, then you'd be a really good violinist. And the evidence for that is that when people recover from depression but then relapse again, the depressive thoughts that they have when they relapse tend to be pretty much the same as the depressive thoughts that they had the first time round. So they've fallen back into a rather similar sort of rut to the one that they were in before. What a rapidly acting antidepressant such as ketamine can do is to lift you out of that rut and take you to another place. But unless you're able to make use of it, there's a good chance either that you're going to need to have more ketamine or that you're going to fall back into the rut. Another analogy is with tree in winter. So when people have been depressed for a very long time, their brains are actually slightly shrunken. And the reason for that seems to be that there's less arborization. If you imagine a tree in winter, there are less twigs and so forth. And what happens when the rapidly acting antidepressant, such as ketamine, is given, it stimulates the production of a fertilizer. And then in effect what happens is that the very tips of the twigs, they start to bud, and it's at those buds that the connections form. So if you bud with the ketamine but don't then form the connections, then those buds are not stabilised, they don't go on to form leaves or new connections. So that's why it's so important to pair the ketamine with some form of new social activity, some form of psychotherapy, but it's more about the activity. And if that activity is too close to what you did before, there is a risk that you're just going to fall back into the rut. So it's best if it's sort of something that's going to help you to not think your depressive thoughts again and get a direction that's established in a different